So to get back to the case, nursing staff noted on admission that Mrs. Tabulum had a deep tissue pressure injury that extended over her left and right buttocks. Staff identified and implemented appropriate interventions to help prevent further deterioration of this injury. Sheila Moffat, our pressure injury coordinator, is here to discuss pressure injury prevention and the treatment further. Thank you, Sheila.
Well, thank you very much, and I'm very excited to be here. It's an honor to me. Thank you. So I'm going to talk about my favorite subject. In our assessment, for sure, throughout an admission, we need to make sure that we're looking at the skin and any wounds that appear. And of course, it's not just initial, and it should be as fast as we can, so we know that we can identify what's community acquired and what is not, but also so that we can treat right away. We also need to look at our risk assessment and of pressure injury specifically, and that's definitely come to bear on many hospitals, that we have to look at what are our rates of injury once they are admitted to our hospitals. And then we need to look at prevention. How are we going to prevent that skin breakdown for that particular patient? The challenges to healing once they do have a break in their skin, and ensure that we are reducing the chance of infection. And we can't diminish the people around that patient, the team, and we need to talk to families and the patient themselves. How can we let them understand that this is they are more at risk as they get older and with the comorbidities that they have. So the initial assessment for sure is important, and daily after that. One of those things that I always talk to nurses about is looking at blanching tests and making sure that we write that down. What's the capillary refill? Is there still good circulation in that area? What is the history of that patient in terms of previous ulcers, and what's the comorbidities? Are we taking those into account when we're doing our assessment? Do we acknowledge that they have sensation or blood flow or skin conditions that need to be followed through while they're in hospital? So we did identify that this lady was laying on the floor of her home for at least, under maybe 24 hours. And this is the kind of injury that we definitely see, is that deep tissue injury when people lay on a hard surface for too long in one particular area. Other ways that we see that happening is if people stay on OR table too long. So they say after 4 hours they are at risk for some injury like this. We've also seen, unfortunately, some patients who have had too much pressure from a bedpan that's been there too long, and we'll see injuries like that, or devices like devices on your feet for foot drop, or that they're too hard and then they get these areas. This is one of the stages that isn't understood very well, and it is one of the newer stages that's been added to pressure injury in the last years, 2007 in fact. So we find that many staff not quite up to speed on what that might be compared to what maybe stage 1 would be. So we've done a lot of education around that, and I feel like we're really making a difference in terms of recognizing things very early and what is that truly. And that's ischemia to that area. So the thing about this particular pressure injury is that it transitions, and it can be extremely detrimental to the patient. It can go down to stage 4 at the end of the day, the damage to that tissue. So it looks like a bruise-like area at first, and that's what we try to let nurses and everybody know, that it is a bruise-like area. And then it will start to transition into like an unstageable, like this patient, who has darkening and hardening of the tissue. And then we start to see demarking of that area, so the true dead tissue starts to show itself, and we can start to remove that tissue a little easier. We often get plastics involved to help us if it's something that's we think is very deep and needs the tissue removed quickly, so that we can start treating that patient and close it up. This process of demarking and showing what is truly dead could take 10 days, it could take 3 weeks, it just depends on the process. And the other thing that we have to do is look at risk. So this lady is 83 years old. She has many worries as we talk about frailty, and you have been talking about frailty. There are things that we have to keep in mind for every patient. What is their blood work? What is their incontinence moisture factor? How immobile are they? What's the blood supply? And what sensation level do they have? Nutrition, how is that impacting the patient? So all that is taken into consideration when we look at our patients for risk of pressure injuries and skin breakdown. So the tool we use, and many people know, it's called the Braden, and we've increased that assessment in acute care to daily just because we still miss how at risk that patient is and the interventions we need to put in place. So I did a calculation quickly, and one of the things is moisture, which we're not quite clear on because this is her admission Braden. We don't know exactly her moisture, so she did have diarrhea. We don't know if it's accidental or is it controlled, so I gave her 14 for that. But as we go through her days of being there, that should settle out and we should know whether it's a problem, and we will adjust that Braden as needed. But because she is, she has some other things that put her at risk, there's some more questions that come from the Braden. And that is, what level of risk are we? So she was at 13 to 14, but we still have to ask more questions like, is she advanced age, fever, diastolic pressure below 60, poor dietary intake of protein, hemodynamic instability. So if any of those are there, we have to reduce her down and put her at a different level of risk. So she goes down to 10 to 12, or 12 is the number we chose. So there are other things, our clinical information needs to be part of that too. So we can actually change that to even worse or better depending on what we see clinically. One of the things that I looked at in terms of the literature, especially in the orthopedic literature related to fractures and possibility of pressure injuries, some of the studies definitely point to age, especially in this study it says over 80 alone, that puts that patient at risk without any other intrinsic characteristics. So I also looked at some other things that approximately 1/3 of the hip fractures in patients, and they looked at 658 patients over 65 and over, that the incidence, so 1/3 of those patients had injuries within the first part of their stay in acute care. And certainly literature that I've seen before indicates the first 2 weeks of a patient being in hospital is their most acute, they are more at risk for having that breakdown because we don't know them as well either. We haven't figured them all out in terms of their issues. So in 2016, the national body of National Pressure Ulcer Advisory Panel had renamed pressure ulcers to pressure injuries because all wounds are not open yet, so they call them pressure injuries. And they named 6 types or categories or stages. So there are stage 1 where it's closed, where you can see that heel is red but not blanching. The second stage is open but no slough. The third is when we get deeper tissue, subcutaneous or slough, dead tissue in the wound. And then down on the corner there, that once the bone is exposed or palpable, we're into stage 4. The deep tissue injury on that heel, that's the newer one where we talk about bruise-like area, but the depth of that wound is unknown to us. And so that is why it's such a scary stage, because we don't know. In some patients, we're able to see that that's absorbed back because it's not deeper damage, but some patients, especially on the coccyx, we see them, unfortunately, down to stage 4 once all the dead tissue has been removed, and it's quite severe and puts them at risk for infection. So then we also see the unstageable. Again, it evolves, and we find out how deep it is once the dead tissue is removed. So for our lady Alice, her heels are extremely vulnerable, and we have to remember that she's still at risk for other issues, not just the one that she received. So she has diabetes type 2, and she's had it for 20 years. So we have to look at and ask ourselves, what is the sensation of that lady? And is there some diminishment of blood supply? So if we let her just touch the bed, then we will see that patient probably develop a pressure injury of the heel. So we really need to make sure that she is protected. And we do see in our prevalences numbers like 20% of our pressure injuries are heels. Now, having said that, we've made a big difference, I must say, in the interventions that we put in place for our hospital, and allowing the nurses to make those interventions quickly, and recognizing redness as the indicator for removing those feet off of the bed with pillows or boots. So interventions for immobility are huge for this population, obviously, and we want to promote the change in position every 2 hours. We need to promote it for circulation, to allow them to not get pneumonia, lots of other reasons, and skin as well. Using pillows and wedges are a really good intervention for some of these patients, because they can pull the pillows and put them out. Sometimes the wedges are something we have to go to. And then we need to sometimes consider those better surfaces for patients. They need to protect their skin, reduce moisture sometimes from incontinence, and also decrease the pain to make them more comfortable. So when we are deciding on a mattress, we really do think, some nurses will ask me, well, when do I decide when I should put a patient on a mattress? Well, we need to think about immobility first and foremost. And sometimes people think, oh, well, they get them up in a chair so they're more mobile. But that sometimes isn't enough for that patient yet. So we have to think about the 24-hour clock for that patient and think, okay, they've been up in the chair for 3 hours, but they're still spending how many hours in bed, and often in the same position if we can't get them turned. And especially when we're talking about delirium, and it's very difficult to make a patient stay on one side when they can't understand what we're trying to do. We know we're trying to do our best, but sometimes it's very difficult with the patient population. So if they have extreme weights of very, very high weights or very low weights, they are more at risk for the bony prominences to get red. If they have a present injury, we need to make sure that we're reducing down that pressure for that patient right away so that we can do the best to heal them. And any high-risk patients that we identify needs to be looked at. Other things, of course, we need to be working with that physiotherapist. It's always a partnership to make sure that we can look at what is the best kind of situation for that patient, given all their concerns. looking at what's the best time to mobilize, how's the best way to transfer that patient to keep their bum safe, especially this lady who has both sides of her bottom damaged, and how will we keep them from having pressure. So keep on moving using small amounts of time periods on certain surfaces. Also working with the OT and saying what do we need in terms of that cushion while they're sitting up for those 3 hours or increased time. How can we make sure that they equally have a surface on the bed and a surface on the chair that they're sitting on? And protecting heels. So we need to have that strategy of the best practice is not to have the heels touch the bed at all. That is best practice. So how are we going to do that? It's either with pillows or with boots. And I always say to nurses, the boots aren't always the answer, and especially I have a story about a patient. We tried to put these boots on a patient because he was very thin and he was touching the end of the bed, and it was very clear that he could break down quite easily. So we gave him the boots because he moved around so much, but he had a delirium and maybe a dementia, I don't know, as well. But he had imagined that the boots that we gave him were army boots, and who's going to pay for those army boots? And he went on and on. He kept the whole 4-bed ward up all night because he couldn't. And the nurses were trying their best to keep those boots on. But unfortunately, the agitation that we caused that patient, it was just enormous. So we have to look at what's the best for the patient and what we can manage. And one thing doesn't fit all patients, for sure. So again, moisture. So we don't know if this lady is or isn't incontinent, but definitely if she is incontinent, this is a big concern because now she's going to have an open area very soon on her bum because that transitions to an open area. And then we have to get it cleaned up and get to the good tissue and grow from the base of that wound. So how are we going to protect that patient from incontinence? And we really have to make sure that we're addressing that. So if it's diarrhea, this is huge, and we need to make sure that some antimicrobials are there for that patient, or what kind of dressings are going to keep that stool, urine out of that area, right? So we need to make sure that we are using incontinence products that are working. Are we able to be diligent enough to take it away quickly, or is it so damaged that we need to look at, unfortunately, devices? And we always fight against, should we be putting in Foley catheters, of course, because we don't want UTIs, etc. So it's always trying to find the balance for that patient at the right time and then removing them as soon as we can. And another thing is that equally, just not the ulcer that we already have, but we can create other ulcers with that incontinence, and we certainly see that with so we've done the prevalence for several years now, and we do see that in other studies and in our Nova Scotia Health study that there's a high correlation between incontinence and having a pressure injury occur for that patient, and also incontinence-associated dermatitis, which is can initially start breakdown and fungal infections occur. So, of course, nutrition, we need to work with them. Many of our patients who stay are elderly, and I think the nutritionist is going to kind of cover that quite nicely, so I won't go into too much detail about that. But we do need to make sure that that patient gets blood work so that we know where they stand, what things that we need to address, and some of those things the nutritionist can help us with to ensure that we're optimizing that patient for healing. So consult that dietitian, make sure that they're part of the team. If we know we have a pressure injury or other ulcer, we need to partner with that person to ensure that we have the adequate enough protein for that patient specifically. So if that patient, you can work with the dietitian to encourage and increase the protein intake that's being lost by the exudate that's occurring in that wound. Friction and shear. So of course, the head of the bed, we want to make sure that's down as we can, and of course we fight with other things and protocols that are needed. So we have protocols for NG tube feeding. If they have that, they have to have their head up and they have to sit up constantly. And then the other thing is if they have congestive heart failure or those kind of complications, can't breathe, and many patients need to have their head of the bed up for that. So we do have to consider other things, but if we can keep their head of the bed down, that would be optimal. Using transfer sheets to reduce down the friction for that patient when they're moving, and also sometimes using the knee, the end of the bed, to put it up when they're sitting up so that they don't keep sliding every time. And factors for healing are that again, optimizing that nutritional status, maintaining the glucose control. So if that's way out of whack, then we're not really, like, we have damaging cells. Early mobilization, and we've talked about this with the other groups, it's definitely a benefit for that patient to be optimized and moving for so many parts of their body and systems. And skin is one of them. So, and reducing the skin pressure and shear as we can. Blood flow and oxygen is so important. So if our hemoglobin is really low, and I know that we can't sometimes address that, but we have to realize that if their hemoglobin is below 80, below 100, then they're not optimized for healing. Can we do something about that? Well, nutritionally, we might be able to help that. And again, we don't do transfusions just at that level, usually. Medications such as steroids can impact the healing as well and hide infection, so we need to be aware of that situation. And adherence and adjusting behavior. So we talked about certainly delirium. We have to have buy-in from our patients that they want to turn or that they can understand what we're asking them. And then of course, talking to families and making sure that they can help us in any way to promote the activities that we need. Smoking, that's going to be a hardship on the healing process too. So, and the glucose control, right? So are they actually doing what we ask them to do in terms of nutrition? Lots of things. And one of the things that we need to keep in mind is there an infection, impending infection? So they are at risk. They've been laying on the floor. They probably picked up some, it's not a great place to be lying on the floor and there's nowhere to go to the bathroom. So sometimes we have some infection related to the wound. So we need to keep an eye out. Is it contaminated? Do we have local infection or do we have spreading infection? Especially when we see bone, we have to watch out for osteomyelitis. So there's so many complications that could occur with that wound, and we have to keep an eye out for that and bring it forward. So this is a slide from the International Wound Infection Institute, and they talk about what are the considerations we have to keep in mind. What are we seeing, the redness around it? Do we have hypergranulation tissue? Is there bleeding in the wound? When it's a chronic wound, we should be past the bleeding phase. So there's many things that we should be keeping in mind and treating as soon as we can. So local infection, this is a picture of a patient with hypergranulation tissue and bleeding. So that's a local infection, it's considered local. So are we using antimicrobials for that patient to bring down the infection, and then we can avoid antibiotics? It's really catching those pieces in the local wound to make sure that we are addressing it quickly and turning it around. Similar to another one is Pseudomonas, we can catch it early or then it can go into the bone and become septic. So we do need to be diligent. So if we're down into the deep infection or osteo, are we recognizing it early and treating it? So it's so important that we involve that patient and family, and certainly my grounding is from rehab, where the team approach is the best, and including the patient to do self-management, whatever they can buy into, whatever they can put into their daily lives, because this immobility may be a permanent thing for that patient, and we have to teach them this is your new life at a certain level, whether they're in a wheelchair or what, and sitting in a wheelchair all day comes with some immobility problems like skin issues. So we need to be teaching them all the time what they can do to help themselves. And that's it for me. I didn't address the surgical site, but that wasn't, we weren't going to talk about that. Okay, thanks.